Okay. Well, I have mine on, and they can, not that, what we're going to talk about mostly, hopefully will pertain to the slides. And, we haven't, we haven't done this in quite some time. And we worked pretty long on trying to make this a very beneficial and informative hour to understand how you can help build a dental sleep practice, or build dental sleep into your practice with medical referrals. So welcome everybody for being here. And it looks like it's right at 8 o'clock here in the west coast of Florida, and I guess it's 7 there in the central time in Rich's area. So we'll go ahead and get started. I'll start with a little housekeeping by saying that we have everybody muted because we have several hundred people registered tonight, and we will get to all your questions. Just type them in the question box, and we will be happy to answer them either written or verbally, and we'll stay on as long as need be afterwards. And if you have questions about CE, we'll answer those in a little bit as well. And tonight we're going to talk about referrals, how we develop medical referrals. And Rich, I think this is really kind of close to home for us because it's much easier to build a dental sleep practice now by treating your own patients. We preach screen, test, treat, and bill. It's one of our mantras that we say, and I think it can help build a practice because you can screen your patients and you can get them tested a lot easier. And we are really the specialists, obviously, for treating. But when we started, it was a lot harder to do that because you had to work with sleep physicians to really get patients. I think you and I pretty much build our sleep practice based on this model. Would you agree to that?
Yeah, well, if my picture was up there, you'd understand why the first guy through the door always gets bloody, So 20 years ago when we were doing this, it was certainly harder to do than it is today. So we do have ways for you to screen your patients and get sleep testing. So we're not suggesting that you do an end around with the medical professionals. In fact, to the contrary, we want to talk today about how you can help build that, and in your own community. You want to be that go-to guy, and if there's already somebody there or some gal there, we'll give you some pointers about, how you can build that. But you're absolutely right, Guy. It is a whole lot easier today to do that than it was 20 years ago when we started.
Yeah, we're going to talk about how if you start with your own patients, you have an opportunity to actually give the sleep physicians and the general physicians, the whole medical community, some of your patients because you need their help. And I think we want to start, and I know this is not what this whole hour is about, but I think you have to understand why we're involved in this. It's 1 in 5 adults has sleep apnea. It's the most undiagnosed, untreated serious medical disorder in our country. It can directly lead or have an impact on everything listed on the screen here, from heart attacks to cancer to impotence to diabetes. And so, if you want to go and spend your day and doing something worthwhile for your patients, which dentistry is, of course, but there's nothing that can be more worthwhile that you can do than to help your patients who have this problem either know they have it, and then help them treat it, because it's a serious life-altering problem that we as dentists have just a really great opportunity to help. So I think what we're going to start off with, Rich, are a few studies. And I think the purpose here is, first of all, to understand really how bad apnea is for those of you who are kind of new to this. But you have to understand these studies, because as we're going to talk about a little bit later on about actually going and walking through the door, talking to the physicians, and we want to be able to talk eye to eye with them, toe to toe, whatever you want to say there, and we want to make sure we have some information that they'll find valuable. They do a lot of, if you bring them research and so forth, I've found that they want some facts, and I think we have 2 or 3 studies here that I have in my with me when I go to most physicians' office, and there's other ones we might talk about, but these 2 or 3 here I think are real important. Rich, are these the ones that you use as well? I'm sure you have other ones.
Yeah, well, we've only got about 500 to choose from, but these are certainly some of the top ones that you want to do. And this, what we have to understand as a dentist is when we cross that line into medicine, most of medicine, I won't say 100%, but I say 98% of it, simply goes by evidence-based data. It's Just that simple. You can talk all you want about essential oils, and I'm not knocking them, but until we get randomized controlled trials that say it does this or it does that, we're not going to make any inroads with that kind of stuff. So we're going to show you some studies here, and I love this Wisconsin sleep cohort, guys. This is where we took 1,000 state employees from Wisconsin, and that's a very big N for any type of study, and we give them a sleep test, and then I think we're in year 18 or 19 now of this study. We're almost following them 20 years. Right. And we've got, all of these people in this study, and then we're going to look at what happens to these people. So if they're normal, they have an HI less than 5. HI is an apnea-hypopnea index. That's how many times you quit breathing per hour, those of you guys that are just getting into that. So what we have is normal, mild, moderate, and severe. And we see on the left side, we've got percent surviving. So we start out with everybody alive. And if you go down to that severe curve, you're looking at people who have HIs over 30. At year, what is that, guy? Maybe 18. 12, 13?
Yeah, I think they did them every 7 years or so. So yeah, it's pushing 20 years. Yeah,
but we see that huge drop-off in mortality. I mean, these are people that are dying. They're not just feeling bad and sleepy and tired. They're dead. They're 6 feet under the ground somewhere now. Right. So this is one of those things that I personally, I don't think a lot of primary care physicians know. The sleep doctors certainly know this.
Yeah, absolutely. By the way, Rich, pull your mic just a little bit away from your mouth, maybe, if you can. I'm getting just a little feedback from your breathing there. So yes, and one thing I think that even though the primary cares may not know this as well as they should, so we should certainly educate them. But also the sleep physicians know this, but they're kind of hung up on this AHI 5 thing sometimes. And what I like to explain to them is, look, doc, CPAP's great if they'll wear it. And, dental devices work really well. When we get down to the next study or two, we'll talk about how dental devices can move people pretty predictably, 69% by one of the studies we're going to show, from down here in severe up here to mild to moderate. So I want the physician to understand we don't always get them up here to the above 5, but if we can take someone who actually will wear their device every night and take them from a 57% survival rate to the high 80s, that's a fantastic service for that patient, certainly considering that they may be someone who tried CPAP and failed. So I think using it to talk to the physicians about what our treatment goals are is really important, because we're going to concentrate on that as well, kind of getting the physicians out of this mindset that the CPAP's perfect because it gets an AHI less than 5. Well, it doesn't always even do that, and especially if you're not wearing it. So this is just one of the studies that we'll bring forward, especially now when I talk to cardiologists. I use this study. This just came out last fall, 2,687 patients. I mean, this is a big study. And the purpose of this study was to see, we're going to give these patients who had some sort of cardiovascular history, some sort of a serious event or reason for us to think that they're at cardiovascular risk. And we're going to give some of them CPAP, and we're going to give other ones we're not going to give the CPAP to, of the patients who have apnea, severe apnea, but don't have symptoms. Because, people say, well, I'm not sleepy, so why should I wear the CPAP? Well, we say because, you got severe apnea. We go back to the previous slide, 57% survival rate after 20 years. Let's do something about this. And so this study came out last fall, and what we found was really shocking, that the people who were given CPAP versus the people who weren't, for these severe apneic patients with a history of cardiovascular problems, that there was no significant difference between the two groups. None. Clinically, and that so here's the conclusion, and that we have to ask is why not? And there's speculation on this. I think the most logical reason, if you read in the study, that the CPAP patients were on average wearing this 3.3 hours a night, so not even half the night. So we assume maybe that had a lot to do with it. So again, got to be careful how you present this information to the physicians, but we've got to be confident in what we do, and we have to be prepared to be a little bit, I wouldn't say confrontational, but be willing to express a different point of view than maybe they're used to. It doesn't always go exactly the way you want, but most of the time it will, and you've got to persevere. And then, Rich, this study, we've been using this for probably the longest, wouldn't you say?
Yeah, we have. So Arnold Hokema out of Sweden did this for his doctoral thesis. You know, that's 10 years ago now, Guy. It's hard to believe that.
Jeez, time goes by.
You know, this is by far the single best study that is a direct comparison of age and sex and BMI matched patients, how severe their sleep apnea was, and we put one guy on CPAP and we basically put his twin brother on a dental device, and then we see what happens. So it's a very, very well done study. By the way, you can get this book, which is sold through the Academy of Dental Sleep Medicine, is the best place to get it. I think they charge $20 for it, something like that.
If you remember.
And what do you think, Guy? An hour and a half, you can probably read the whole book.
Yeah,
and,
absolutely.
I would recommend that you do that. But we're comparing a dental device with a guy and literally his twin brother or twin sister with CPAP. And as we go through this, you know, we're looking at, you know, if back 10 years ago, Guy, we used to just have to, the standard of care was somebody had an AHI of 50, we only had to get it, you know, below 20. If they had an AHI of 100, we had to get it below 20. So now we want to get it below 10. So we want to reduce it by half. So if you start at 15, you're supposed to get it down to 7.5. If you start at 20, you're supposed to get it below 10. If you start at 50, you're supposed to get it below 10. And we got to remember, going back to that first study that we had, that Wisconsin sleep cohort. By the way, is that better, Guy? Can you hear me breathing now?
Yep. No, you're much better. Thank you.
Okay. I was just so excited talking about this before. I was getting
hyperventilated.
Just breathing hard. So, but when we look at this, you know, man, there's really not much difference between the oral appliance and CPAP until you get down to the severe patients. You know, interestingly, Guy, the non-severe patients, the dental device was actually better in this particular slide. Yeah. So, you know, when we go to the severe patients, or we go to a little more strict criteria where we have to get the AHI below 5 and reduced by 50%, well, CPAP shows a difference now, you know, overall. In the severe, there certainly is a difference. So like Guy said, the expectations and the goals of your treatment when you're talking to physicians, when a physician says, well, it's just not good enough if we don't get the AHI below 5. And we can say, well, according to this one study at the Wisconsin sleep cohort, if I get it below 30, I'm actually adding 10 years to the guy's life. Right. If I get it below 15, I'm probably adding 15 years to his life. So yes, although it's not perfect, it's still a whole lot better than nothing, number one. The second study we showed you, that for non-sleepy apnea patients, there wasn't a difference in cardiovascular events. Right. And that is because most patients won't wear their CPAP more than 3 or 4 hours a night. So we picked these 3 studies to show you that a lot of the arguments that the physicians will bring up, we can kind of at least give a strong rebuttal to. Wouldn't you say, Guy?
Absolutely. I want to talk about that, the effectiveness of treatment in just a second. But I really think the key take-homes here are, 84 to 80%. For mild or non-severe, and then this 31%. Even if we want to get it below 5, and then I want to back up just so you get these numbers. I think memorizing these numbers when you're talking to them. Hey, 69% chance we're going to take that person from severe to a more mild case and get their AHI below 20. And like you said, couple that with the Wisconsin. So those are 3 numbers I remember: the 84, 69, and 31% from this. And this is in chapter 4 of this book. The book has a lot of other good information in there. We'll talk about when we go visit the offices. I just buy these books by the dozen. I put a little sticker on chapter 4. This is in the appendix, this AHI of 5, but when they rescored it, I put a sticker back there. And then what I do is I write a little note in the front of it: hey, Dr. Smith or whoever, looking forward to helping your patients live better, live longer, and something along that line, and just give it to them when we go in to see them. I think the last thing we'll talk about on this, and then we will talk about the treatment effectiveness and what this means to us as we have our discussions with the physicians, are, the practice parameters. We start off a lot of times our our webinars with the practice parameters, but we're not going to rehash those too much today, except to show that up to 83% of the patients, these are from the 2015, by the way, AASM and AADSM, American Academy of Dental Sleep Medicine and American Academy of Sleep Medicine, combined to put these together. 83% of the patients are non-adherent to their CPAP, and that the mean disease alleviation calculations of oral appliances may be comparable to CPAP. And the reason is what do we define the effectiveness of treatment? Well, it's not just the efficacy of the treatment. It's the efficacy times the compliance. And Rich, I think you came up with this, or Keith Thornton and you did somewhere along the way, just as an example. I forgot when I first saw an example like this, but this is, I mean, you can play these numbers, but I think we're being pretty generous here, don't you?
Yeah, and you used a lot of big words there, Guy. Man, you are becoming quite the articulate speaker here as you do this more and more. So, we're just looking at, CPAP works better than a dental device most of the time. But the problem is patients won't wear it.
Right.
I mean, that previous slide, Guy, 83% of the patients wear CPAP less than 4 hours a night. That's amazing. And when we look at studies, we don't have them up here, but when you look at studies, most patients will wear their dental device all night.
Yes.
Problem with CPAP, and you'll hear this as you do this more and more, I got to wake up and pee, and man, if I put it back on, I just can't get back to sleep. Or, I do this or that. And that's why a lot of patients will go to sleep with it, but they tear it off at night. They don't even know they have it. So we're just talking about how effective the therapy is, combined with how much I use it. And the end result is that we are probably reducing the apnea load better than CPAP is. And it's not because we're better than CPAP, although in some cases we are, but it's because our patients will wear it. Right. This, I think, Guy, is one of the hardest things to get through to the physicians, because I know that most sleep physicians in San Antonio believe that all of their patients wear their CPAP for 7 hours every single night.
Yeah.
And it's kind of a shock to them sometimes to see those studies. But that's why Guy has picked out these particular studies. And I think you're hitting the nail on the head there, Guy.
Yeah, and again, this isn't all about studies tonight, but if you're going to speak with physicians and get referrals, you've got to be educated. Some of them are going to really quiz you on things, and they're going to challenge you, and that's fine. Don't be worried about that. Most of them are going to be very reasonable, but you have to be prepared, and you've got to be confident in what you're saying here. But I think this really hits home sometimes when you think about it. The American Academy of Sleep Medicine says for people who have obstructive sleep apnea, there's two choices as a first line of therapy: CPAP and dental devices, period. I mean, there's other things we can try after that, but this is the front runners, the first line of therapy. And, if 83% of the patients aren't wearing their CPAP the majority of the time, then dental devices are needed, and they're going to certainly have their place. And so if you're worried about being a market for this, there certainly is one. So, by the way, we see you putting questions in. We're getting to all those as we go through the night. We're typing the answers in between talking here. If it requires us verbally talking about it, we'll do it at the end. We've been doing this a long time. We like to take a moment and mention that we've been doing this, over 30 years between us. I'm the guy there I'm Guy, and Rich is the other guy there on the other side. 30 years or more, I guess, between the two of us now at this point.
Well, I'm in 18 right now, so getting close to 19 myself.
Yep. So I'm about the same, just maybe a year behind. So, and we've done thousands of devices. What we do at DS3 is we help dentists succeed at dental sleep medicine. You can read our mission statement there, which we're very proud of, and we look at this every day, and we want to continue to be the most trusted, innovative, customer-focused provider of solutions in dental sleep medicine. And we do this through education, our coaching, our software support, and we talk about the 4 pillars: screening, testing, treating, and billing. And And what we basically do is help offices succeed and accomplish those systems in their practice. If you're interested in learning more about what we're doing, we do courses. We've got a few left this year. If you type in course, it'll give you $100 off a 1-day course, which makes it really, really reasonable. So go ahead and just type that in any time throughout the night. And if you just want to learn more about what we do, just type in consultation, and we can not only tell you what we do, but we'll also, if you have a specific problem or question that we don't get to tonight that's maybe more complex than we can address in this time, or just want to pick our brain, we have a room full of dental sleep experts. That's all they do every day is help dental offices succeed at dental sleep. So take the time, talk to them. It'll be well worth it. Just type in free consult or consultation, something along that line, and one of our member support experts will call you tomorrow. Rich, I know that you're excited about
I'm looking forward to this again, man. Come on down, you Northerners, come on down to Florida. The hurricane season's over by February, so we'll get you in. And we did this last year. It was our inaugural symposium, and we filled the room. We got a lot of good speakers. There's a lot of good topics, and we really focus this entire meeting on implementation things.
Right.
It's nice to know what the apnea does to the cardiac output of a 4-year-old with sleep apnea. But we are going to focus on tips and tricks and things that you can do in your practice, and how to take bites, and how to. I'm going to talk a lot about. I've been doing a lot of advertising lately, and in my practice in San Antonio, we make a lot of dental devices, and I'm going to talk about what has worked for me and what hasn't. And Guy, what are you going to talk about?
Well, I think we're both going to talk a little bit about together on some subjects, but I'm going to elaborate on this referral relationship that we're going over tonight. It's a big meeting. We'll have a lot of other people there that can help with every other aspect, from medical billing to coordinating with sleep specialists. You can read them here, and I can honestly say it's the best. We almost named it the best darn dental sleep medicine meeting in the country, because last year we heard that from almost everybody who attended. I would say everybody who talked to us said that. It was just a phenomenal meeting. So the rooms are going. So if you want to sign up, we've got a really great discounted room at the Hilton on Clearwater Beach in February. So don't call us in January 15th and complain that the rooms are sold out, because they got a really good discount on that. So you might want to sign up earlier than later. And again, here's what we do. I think we've talked about it enough. If you're interested and we need your help, again, just type in consultation and we'll help you. Last bit of housekeeping on this, and we'll get into, now that we have the studies behind us, how we actually make these connections with physicians are. Our next webinar is Tuesday, October 10th, and we're going to talk about some clinical pearls. And I'll bet it's been 3 or 4 years since we've done this one, Rich, and we got some new stuff on here. You can, everything from making a denture to increasing or decreasing retention without taking the device back to the lab. And this is just some real quick 5-10 minute topics that'll just make your dental sleep life better, that we've learned after doing roughly 4,000 devices between us. So again, that'll be October 10th, 7 p.m. Central. Do you ever have this happen, Rich, when you go to a physician's office?
I don't think I've had that happen, Guy, for at least 3 days.
What's it been, 3 days since you've seen a physician? So I think the point here is you're going to get rejection. And, if you're not good at this, then maybe you need a team member to help you with, and we'll elaborate on that in a moment. But, it's like dating. It's like fishing. You're not going to catch a fish every time. You have to be comfortable with the fact that some physicians aren't going to be open immediately to what you have to say. Now, that's not to say that this hand that's out in front here can't gradually turn into open arms, because I've had physicians that I had this is what I was met with. And after several years, several months, sometimes just several weeks, you treat a patient or two, somehow they hear about you, and this rejection becomes open arms. So just don't it's not personal. It's a lot of times they're busy, and a lot of times it's that they just don't know what they don't know. So you've got to be comfortable with that, and you've got to learn to persevere. if you get your feelings hurt easy, and then again, it doesn't mean you have to do this. You can have a team member do it. But I would say, Rich, I think one of the reasons you've done so well, you're one of the, you've thick skin and hard headed. You don't take no for an answer, do you?
You should have just kept with thick skin, but the hard-headed.
Yeah, well, I'm hard-headed too, so both. That's kind of funny.
But you're right. If I can, Guy, let me tell a quick story. So we're trying to get a prescription letter of medical necessity for one of our patients, and we send the request to the ENT. He says, "No, I'm not signing that." So I didn't go in the corner and cry. I didn't, tell the patient that, we can't do this now or something like that. It was. Can you still hear me?
Yeah, sure, you're fine.
Okay. And I picked up the phone and called him. I said, "Hey, I want to talk to the doctor. We've got a mutual patient. Could be life-threatening." I always say that. It isn't right at this moment, but it usually gets them to the phone, right?
Right.
And I say to the guy, "Hey, this is who I am. This is what I do. We have a mutual patient. He's tried CPAP 3 times. He's failed it. Yes, he has severe sleep apnea. No, he's not a great candidate for a dental device, but since he's failed CPAP, he is a great candidate now. And I think we can really help this guy." And he goes, "What was your name again? Can you send me some business cards and brochures, and I'll go ahead and get that letter back to you right away." So that is a very good example, Guy, of they don't know what they don't know.
Right.
So, these physicians out there, if you guys read that green book and you read those 3 studies that we told you, you're going to know more than a lot of the primary care physicians. You won't know as much as the sleep docs, but you do have to be persistent. You have to persevere, and you have to look at these rejections as opportunities to succeed. That guy now refers me a patient every week, Guy.
Yeah, I think the key thing.
I just turn and run.
Yeah, I think the key thing you said there is too that it's these. Most physicians are good people. They care about their patients, but they're busy, and they don't know what they don't know. So again, I think you just said it perfect. That's a great example. I'm sure you have dozens, if not hundreds, of examples like that. So do I, and you just have to believe in what you believe here, and accept that they care about their patients too. And it's not that they're bad or that they don't want to listen to you. It's just that they're busy and that they haven't seen the need for it yet. And you, when the light goes off in one of them, wow, it becomes really fun, because then they really get it. They really start wanting to work with you, and it becomes really I would just say one of the more enjoyable parts of my career. I've been a dentist for about 30 years now. When you get a physician that understands that it's just like working with your periodontist that you like, your orthodontist, but even to another level, because you're really affecting these people's lives in a great way, and it just becomes extremely rewarding. So hopefully we've convinced you that you gotta stick with it, and it's worthwhile. I don't think I have everything listed here, Rich, for where you can find referral sources. I think we're talking about medical referrals primarily, but there's a unlimited.
That's a pretty
number.
good list there, though, Guy. That's a good start. I walked through the door of 500 physicians the first year I did this.
Wow.
I didn't have any patients. I didn't have anything else to do, so I was out there, beating the bushes down and doing that. And don't count dentists out. Some dentists don't want to do this. And you got buddies out there, and if they don't want to do it, have them send the patients over. DME stands for durable medical equipment. That's where you get wheelchairs and CPAP and crutches and things like that. These are the people that they bring the CPAP machine back and they say, "Hey, I just can't use it." So sometimes a $10 an hour clerk in that store can be a referral source to you.
Right.
Well, what do you do with those people? Because they're asking the clerk. They're going, "Man, I can't wear CPAP. What do I do?" "I don't know." "Well, hey, this dentist came by the other day. He dropped off his cards. Maybe you should give him a call." So, this takes time and effort. Like Guy said before, you do not have to do this, but you need to have a team member who believes in what you're doing get out there and beat the pavement sometimes.
Yeah, I'll mention on team members, we have had contests where we have magnets on our team members' cars about helping sleep apnea and snoring, and whoever gets the most patients come in. I know one of our friends, Steve Carson, said I know that he took his whole team on a big trip over who brought in the most members and how many cases they did, and he thought it was going to take him 3 years, and it ended up taking him about 6 months to get the numbers, because the team members can find these referral sources. They can, if they believe in this, they can do it too. And I've certainly had patients who tell everybody about us. So, finding these, I know some dentists aren't real comfortable knocking on a physician's door or doing lunch and learns, or maybe speaking, I'll mention what Awake is in a minute, or some of these things. And if you're not comfortable with that, or you're too busy, I'm comfortable doing it. But when I started, unlike Rich, I had a busy restorative dental practice. And I talked to Rich, and Rich is like, well, you've got to go out and meet these physicians. And I said, I don't have time for that. I've got, implants and everything to do. So I hired an outgoing team member who was one of the head people that started to help in my dental sleep practice. And this has been only about 10 years ago, really, that things got extremely busy once I hired her. And she wasn't afraid to do all these things. She would go on what I would consider a scouting mission. She would knock on the doors and take, brochures, some cookies, what have you, and say, hey, here's what we do. And she'd get the door, kind of halfway open and some shut on her face and the others, but some would be open. And once she vetted these referral sources and they seemed interested, and maybe they send us a patient or two, as we'll talk about, then I would take my time to go meet with them once we felt that it was a worthwhile expenditure of my time. Because again, I was busy in my practice. These clubs that want people to speak, I've gotten so many patients from those. And Awake, I want to mention, in most areas in the country that have any population at all, if you'll talk to your local sleep labs and physicians, they have, it's called, I don't remember what the acronym stands for, but it's Awake. And these are CPAP intolerant patients for the most part. And they have a group, what's it called, Rich? I'm having it's like AA for CPAP intolerant patients. I can't think of the right name, but anyway, they ask. I
just remember the Awake groups. That's the only one I remember.
Yeah, but basically it's a support group is the word I was looking for. It's a support group for people who have apnea, and they're always asking for speakers. And we talk at one every 6 months or so, and it'll be a room full of 30 patients who can't wear their CPAP typically, and you have a 15-minute PowerPoint you show them, or just get up and show them some devices without a PowerPoint. Boy, these people are interested. Medical meetings, you have a booth at some meetings you don't get much action, but when you go to a medical meeting or even other type of chamber of commerce meetings, things like that, you'll have all kinds of people come up to your booth if you have a sign that says stop snoring and sleep apnea. People want to talk about this, and if you just mention it the next time you're at a meeting with you meet a physician to go in. I went with my mother's physician. She went back to him today, but the first time I went to her cardiologist, told him what I do. Well, next thing you know, we've got a lunch scheduled. He had no idea, because I was there to help my mom with her medical decisions, and just talked to him a little bit about it. And now we've got someone we can talk to. So finding the referral source and then finding a system to kind of vet them, I think, especially if you have a dental practice, is important. Kind of went off on there. Rich, you have anything else to say on that?
No, but we try to stay focused. We kind of started this with building that medical referral base, and we told you a couple things to get a couple of other things. So we started this as a real quick review. You got the studies. You're going to go out. You're going to start to work this medical referral. So they don't know what they don't know, most of them. And you just get a couple of these studies behind you, and you start throwing around AHI and RDI and LSAT and a couple of these acronyms. You're probably talking over the head of half the primary care physicians.
Right.
So, and what do we say, Guy? You fake it till you make it.
Right.
You certainly act like you know what you're talking about, when you get out there and do it, because you have to act like you've been doing this for a long time. Somebody says, well, how many devices have you made? I tell people when I do a course, well, I haven't done one since yesterday. or I haven't done one since last week. You know, it might have been your first one, but that's kind of you know, you have to be confident. We all start somewhere and we do this. And we're just giving you some other ideas outside of that for you to go look at as well.
I think go back to our sleep, test, treat, and bill model. If you screen your patients, and if you begin treating some of your own patients for snoring or OSA, then you're going to communicate with the physicians that patient already knows, and maybe the sleep physician that diagnosed them if that already been diagnosed with apnea, and you're going to communicate via letters, which we'll talk about in just a second. But then when you're finished with their treatment and you've communicated with them, then we make a phone call to that physician and say, hey, we treated your patient with the dental device, what we call dental sleep therapy for OSA. How'd we do? I sent you correspondence. Can I do anything different? I just want to make sure you got all my letters, and what else can we do? And they may say nothing, or they may give you some advice, or they may say, this is great. I didn't know there was someone around that really understood this. And if they seem interested, that's an open door to maybe having a meeting with them. And then what we kind of do is we have a list of the physicians who kind of get this, and continue to be in front of them with meetings and letters, and just making sure that we're always in communication with them. And so it's almost like watering your plants. I think, you just can't assume they're going to keep sending you patients. The good referral sources need to make sure that you continue to reach out to them, make sure you're doing everything right. Stop by their office, bring them brochures, meet with them for lunch. And by all means, it really hinges on quality and consistent communication. And I think the backbone of that are the letters. Rich, I think I'm always amazed because you see more patients than I do these days. How many letters, how many letters you've written, in the first 6-8 months of this year?
I do, but you wouldn't believe me if I told you guys. So in the first 6 months this year, we've written over 4,000 letters. So
wow.
I don't sit down and handwrite every one of those. I use the DS3 software. That is what we do. That is the backbone.
Speak up a little, Rich.
Of our system. Huh?
Speak up just a little.
The backbone of all of our system. The DS3, that I write the letters. So when we have a tracker, what do we do today? What are we going to do next? But this is the letters are the water for the plant that Guy is talking about. If we use that analogy, we don't do it every single time, but we like to get all of the doctors that the patient has. They have a rheumatologist, they have a urologist. I mean, you just can't believe where referrals come from. So we write a letter and we say, hey, Dr. Guy Yatros referred this patient. He has moderate sleep apnea. He failed CPAP. We've made him a dental device. We're seeing him for follow-up now. The patient's wearing the device and he's doing very well. We'll keep you updated. And then we copy that to all of the other doctors. And Guy, I can't tell you how many times, at some point somebody calls back, or I even had a guy yesterday. I opened the letter, Guy. It was a letter that I sent, and he took the letter that I sent. Okay, and it's poorly printed, so it was a fax. We do most of this through our digital fax system, and he wrote on there, "Man, it's great to know that you exist.
Wow.
I see you as being a great resource. Thanks." He took the letter that came off the fax machine. He wrote that on it. He put it in an envelope and said, "Hey, mail this back to Drake."
Wow. Yeah, it's it's a way that to build your practice, and it's also the right thing to do. I mean, we need to keep our physicians updated. If you send someone to periodontist and you don't hear from them for 9 months, you're not going to send anybody else there. So it's our way
That's a good point, guys.
So it serves two purposes. And like you said, we don't do it every appointment, but certainly referrals, consults, treatment decisions, update letters. In our office, we try to go more than 6 weeks, certainly no more than 8 weeks without a letter. We try to stay at 6 weeks. If treatment's taking longer than normal, and certainly when we're finished treatment or any complications. And if you don't have a software to do this, you're going to spend
Makes it
a lot
harder,
of time.
doesn't it?
It makes it a lot harder. This is just a screenshot from our DS3 software, and it has all these letters. And the key thing about it that makes it easy is, like Rich said, you don't have to print these out. Saves trees. You select the letter, it populates with all the patient data that you've inputted, and in a matter of moments, you can hit a button and it will digitally fax it through the cloud at no cost to you. By the way, if you had how much would 4,000? What's a stamp these days? Gosh, how much money did 4,000? I don't even know how much a stamp is, but it saved you a lot of money. By not having to melt. All these went through the cloud and faxed, and we know that that's the way the physicians prefer. They prefer
What's a stamp?
Yeah, exactly. We digitally fax, and you don't even have to print these out. So you have to have a way to communicate for those two reasons. So, all right. Well, we'll talk about meeting with the physicians now, and what's our goal here? What are we trying to accomplish? And let's think about, before we walk in the door, what do we want to leave having checked off, as you can see the check marks here. And I think it's always best, and admittedly, not, my wife might attest that I'm not always best about this in my personal life. I try to improve, to ask people about themselves first, and I think you walk through their door, you're in their office, let's talk to them about what they do, what their philosophy is, what their past experience with dental sleep medicine is, what their, is a great, good experience, bad, or they don't know much about it. Educate them on how we perform dental sleep therapy. Rich, don't you think a lot of people just think we're just handing them a piece of acrylic?
Do I think that?
Yeah.
I'm not even sure they. Yeah, I'm sure they think that much. They're like, oh, you just give them a piece of plastic. How much you charge for this?
Right.
That's the kind of stuff I get from the physician. But no, you're right. I like to teach guy that, when you're going to, let's say it's a sleep doc, and you say, hey, Dr. Yates, my name's Rich Drake, and I'm a dentist, and I'm screening my patients for sleep disordered breathing now, and I'm finding a lot of really tired, sleepy patients who snore, and I need a way to get them sleep tested. Do you think you could help me?
Right.
What's he going to say?
Yeah. So I want to give them something first. And then, like I said, I don't think they understand, like you said, about the acrylic. So we walk them through the steps of what I call dental sleep therapy. We call dental sleep therapy. I don't think it's just, here's your appliance. We talk about the exam, the impressions, the custom fit dental device, the adjusting based on symptoms, the follow-up sleep testing, the 6-month recall, managing their side effects, making them an AM aligner. So we let them understand it's a process. It's not, here's your piece of acrylic, good luck to you. And I think the key here, when we leave, we want to agree upon what they, what are your goals if we're going to treat a mutual patient? Here's what we normally do, but if they want something different, like one of my physicians always wants PSGs for follow-up titration. So if he's going to refer me to patients, then I'm going to adhere to that. So we may have different protocols for different physicians. If they say, well, it's up to you, then tell them what you'd prefer to do. But we need to have those understood. And certainly the referral protocols. One thing I'll mention on the referral protocols is, if they're going to refer to me, I would ask them, hey, why don't you ask the patient's permission to send me a fax or call us with their name and number, and that way we can reach out to the patient. And that way, if they don't come in for some reason, you'll get a letter from us saying, hey, we tried to reach them and they couldn't. As opposed to if you just give them my number, they never call, they may not know that they may think we dropped the ball, as opposed to the patient just not picking up the phone and calling. I think that's if they'll agree to do that, that makes it much more trackable, and you'll have success.
That's good. I like that, guy. You're touching on a lot of really good things there, and we want you guys to have the confidence to reach out and talk to these doctors and write the letters, and we're probably not telling you anything that you don't already know you need to do. Didn't you find that in your practice, Guy, that, after a while, you've been doing it for a while and you just start doing the things that you're supposed to do, and then you can even ask yourself, well, why didn't I do this before? I'm not really sure. I think a lot of dentists feel that way. So we want you to be confident, and we want to help give you the tools to go out there and do this.
Yeah, I think the only key things we haven't talked about on here is establish the details of the meeting. Are they expecting you to bring lunch? Are you meeting with one person? Are you meeting with a group? Understanding that, I think I've walked in thinking that it's just me and the doctor, and they're expecting me to have a PowerPoint or something, or so. And I think the key there too on the last line is important. They always run late. So I always try to be on time or early, but don't schedule a patient, 5 minutes to spare because they're going to run behind. So give yourself enough time, I think, is key as you're going to go meet these physicians, because they're not known for being on time, at least in my experience. So what do you want to bring with you? Now, I'm not saying you need to bring all this stuff each time you go, but the Hokema book, Wisconsin Sleep Study, and the New England Journal of Medicine are the three we talked about earlier today. I almost always bring a copy of the practice parameters, either a summary on a couple pages, or I like to bring a zip drive with how many pages is it, Rich? 50-something pages is the actual new practice parameters?
Yeah, it's a bunch, and it's there. And I don't know that we would ever get anybody to do it, but you can put some marketing stuff on a jump drive, and you can do that. You know what I like to think of this, guy, as your bag of tools. Right. You're the AC repair guy, and you bring in your little, bag of tools, and you go, okay, what do we need? Let's diagnose the problem here. What's the problem, doctor? You don't know anything about sleep. Okay, well, let's talk about this. Right. How can we help each other? What are this? So I like to think of this as a bag of tools, and understand. I think the best advice I can give, Guy, these wonderful people who have joined us tonight on this webinar, is these physicians are busy. You're going to rehearse this, and you're going to have all this information at your fingertips, and you're never, ever going to be able to talk about all of it. So just accept that and understand that you want a name with a face. You want this introduction. How can we help each other? What kind of studies are there? Maybe the guy is reaching under the table and he's taking his sandwich out and he's going to eat, while you're talking to him. So you got a few minutes, but understand that you have these things in there, and know that you don't have to talk about all of these on the first visit.
No, and if you do, you're going to not do well. Listen right to what they have to say, gauge what their interest is, and then change your discussion based on what they want to know. And that's why like you Perfect. Said, you don't know. These are your tools. You don't know if you're the repairman. You don't know if it's a leaky pipe or if it's a wire. So you need all those tools. And there's other things. And the other thing, the last thing I'll mention, because I don't want to run behind here on this, but is that I try to find different reasons for these good referrals too. So, something new comes out, device monitor, dual combination, things like the tap PAP, or something like that we might want to show them, or a new tap model or something that we may see. And we want to show them, come in after you've gone there a few times, come up with something new to show them. And when you get through the door, let's concentrate on them and their practice and understand where they are in dental sleep medicine. And then that will help you better understand how to carry on. So if you go and just start spewing everything you know to them, that's not the way to go about it. Understand what they need, what their thoughts are, what their biases are, and preconceived perceptions of dental sleep, and then gauge your discussions towards that, and ask questions towards, really our goal here is to get referrals, right? I mean, so that's our goal, but let's don't jump into that, but let's ask questions like who makes the recommendations for treatment? What do you give for your patients who can't wear CPAP? How would you like to follow up? And how would the referral process go? So we've touched on some of those, but I think the two key things are just like Rich said, don't feel like you've got to take your bag of tools out and show them everything the first moment through the door. Most of the time with a new referral, they're not aware of the practice parameters. So I would say that's one tool that comes out in at least a 2-page summary quite often, because even if they're a physician, and heck, even some of the sleep physicians aren't aware of that. So that one, I would say one of the most common ones I use. Would you agree with that, Rich?
Absolutely. You're right. They don't know what they don't know. And, it gives you a foot in the door. And the up that gives us as dentists is This was put together by the AASM
Right.
and the AADSM. So one is physicians, one is dentists. And it was a joint parameter paper that was put out. So these are your colleagues as physicians and sleep physicians who are saying, hey, you really can use a dental device, and they really do work a lot of the time, and they don't know that. So go back one slide, Guy. There was something on there. I want to say, Guy, the models of the dental devices. I cannot overemphasize what that means. These guys don't know what they look like.
Yeah,
they don't have a clue. They think they got claws on them, or something jumps out at you at night, or, I don't know what they think. But it really, really does make an impression to get a couple of good quality sample dental devices, and you take them and then you just show them and you go, yeah, this is how you adjust it. You make real fine adjustments, and we make this to fit the patient. If it's that, it fits you and nobody else in the world, and this
Right.
is how we do it, and that's why we do this and why we do that. And they'll pick them up and they'll play with them and they'll push on them and that kind of stuff. So I think that's important, the models.
Yeah, and if you get a really good referral source, I actually will supply them with a model or two for them to have, and that becomes really valuable. If they want one, I'll purchase one or two to give them. So, and I think the key of walkaway here is that, look, we want to say, look, doctor, if you send me patients, I'm going to take good care of them. They're going to come back and thank you for sending them to me. And regardless of whether we do treatment or not, or you're going to know what's going on. I'm going to let you know every step of the way, if they accept treatment, don't accept treatment, any complications. When we're finished with treatment, they're going to come back to you. And just think of this, if you're a general dental office, isn't that what you expect from your referral sources as well? And if you send someone to an orthodontist, a pediodontist, or periodontist, or oral surgeon, and the patients come back and go, oh, I hated that guy, and you never get any letters from them, you're not going to send anymore. So I think that's two of the number one and two things that you have to do. And again, establish these procedures. I think we've mentioned some of these already. How are they going to refer? Establish how we're going to treat the patients. Follow-up titration studies I touched on, Rich and I touched on, but I think that's important. How do you want your patients followed up? Do you want us to do home sleep testing? Are you going to do home sleep testing? Do you prefer PSG? Find out what they want. And if they're going to refer patients to you, as long as it's not something that's way out in left field, then you should agree to do it. And I think if I'm going to send them patients, I want them to agree to follow the AADSM, AASM practice parameters. In other words, if they have mild to moderate apnea, they should be given a choice between a dental device and CPAP. And if they can't wear a CPAP, a dental device should be the next in line. And if they're not willing to do that, if they want to give everybody a CPAP regardless of their AHI, then maybe I don't want to work with that physician until they started, adhering to this. And I think the number one thing is
until they see the light.
Until they see the light, and that's the standard. It's not my standard. It's not, it's the standard. I mean, this is not Guy and Rich's development. It's the AASM. It's the American Academy of Sleep Medicine and the Dental Sleep Medicine standard. So they should want to adhere to it. They should understand that this was based on a lot of studies. So, and again, referring to you by faxing us instead of just give them in my card. I mean, you should certainly take brochures and all that with you, but I would rather have the patient call me or fax me or them fax me with the patient's information, because now I'm in charge. We can track that, and they won't think we dropped the ball. That's
a great point. That's a great point. Can I add one thing to that, Guy?
Sure.
Do we have 1 minute? I will see. What I've run across here recently, Guy, is the docs will say, I really want to refer to you, and we take a little referral source. I'm referring the patient. They had a sleep study. They have been diagnosed with this, and I'm referring you to Dr. Richard Drake. All this is filled out with my address and my fax number. We ask them to fax that to us and then hand it to the patient. So the patient has all of my contact information. They have the referral that they're doing, and then we can follow up with the patient as well. Now, one thing that we've run into just in the last year or so is physicians sometimes will say, you know what, we do all of this through our EMR. or our EHR. Most independent physicians are an EMR. So sometimes we have to try to work with that office to get our form into their EMR. And that takes a little bit of work, but I'm telling you, it's worth it, because now all that physician has to do to make that referral is get on his computer and go click, 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 and it's done, and it gets faxed to us. So this comes back to what you said, Guy, before about establishing those protocols and how do we do this? How do the patients flow back and forth, and what do they do?
Yeah, again, we'd rather have the contact information as opposed. So moving on here is one of the things I think a lot of new dentists to this are thinking, I'm going to walk through the door and that third question is going to be the one that they're going to ask me. And you know what? They might ask that, but they're for sure going to ask the top two in one form or another. I mean, the bottom one, they might not even ask. And again, you can fake it till you make it on that one. The number one thing, if you want to get referrals from physicians, is they want to know how much it's going to cost. I do accept medical insurance and or Medicare for my patients. And the answers to this, you can use these on. I'm not going to run through these with you, but basically the answer to the first two are, look, we will see any of your patients at no cost to them. We do work with medical insurances and Medicare, and how much it costs the patient depends on their particular medical plan and their ability to pay. But we're going to work really hard to get them covered and treated when they come in. And most of the time we can make this affordable to them. So I think that's the key. And have you done it before?
That was really good, Guy.
Yeah, I mean, you've got to just let them know.
That was excellent.
Know what that it's, because they don't know if you ask them the same question, they can't say, oh, well, they come in for a sleep study, it costs this amount. No, it depends on their insurance and their ability to pay. And the real two keys, I think, to success, Rich and I have talked about this, is that if you go through all this trouble and you get a referral, let's please don't drop the ball here. I mean, they send you the first referral over. This should be, bells going off in the office. All right, we've gone through the trouble. We've talked to Dr. Smith or Jones here, and he understands. We went over, met his office. Now they've sent us somebody. Let's treat the patient. As long as they are a candidate for a dental device, let's treat them. And if they don't have good insurance, well, let's make it affordable. Let's do it for free. Let's do something. Let's get them treated. And then once we've sent all that correspondence, all those letters, and the treatment's finished, let's follow up with a phone call. Say, how do we do? Can I get the doctor on the phone? I'd like to talk to him. Make sure you got all my letters. Make sure that everything I followed was the way you want it. And if it's not, then let's agree on what we want to change differently. And I think that's if you don't do this step, you're going, they send you a patient and they don't have good insurance. You tell them it's $3,000 and they leave. Or if you do the case and you don't correspond with them, you're going to waste a golden opportunity. And you might even do that for the first few patients, I believe. Continued follow up, Rich. I know you spend more time on this than most people in the country, I would think. And we're getting close to the end here, so I think we've got time to touch on this for just a second.
Yeah, I mean, just try. I think if something's worth doing, it's worth doing right. So provide the correspondence. As dentists, we don't understand that physicians communicate through letters. They simply do. So get in the habit of doing that. We try to make that as easy as we can through DS3. Finding a way to make patients agree to treatment and with insurance is certainly a key, and I love the way you said that earlier, Guy, where, they're going to ask you, well, how much does this cost? I walked into a cardiologist's office the other day. We did a lunch and learn, and he goes, hey, what do you charge for these things? And I go, well, what do you charge for a heart cath? He goes, well, it depends. I go, depends on what? He goes, depends on which insurance they have. I go, that's a good answer, and that's my answer too. Right. And he goes, I think I'm going to like you. We're going to get along just fine. And he turned around and left, I mean, that was it. That was all he was there for, but he sends me patients now. So, maintain that contact, stay in there, phone calls, hand notes. We want to make sure that we water that plant.
Yeah, absolutely. And communication is the key. And again, we've hit this, but I think of all the things we've talked about, you're wasting your time if you don't continually communicate with the physicians. They prefer to be communicated via fax, and these are the types of appointments that we should communicate. And if we're in the middle of treating a patient then we need to make sure that every 4 to 6 weeks, 8 on the we should not go any more than 6. And I say if we go to 8, I look at someone and the physician hasn't gotten a letter in 8 weeks, and I'm talking to my team about what went wrong and why didn't we get that accomplished. And I think the bottom line is, there are tons of patients out there. Furthermore, there's tons of physicians. They just haven't taken the bait yet. I mean, it's, you may have to move the boat around a little bit. Rich loves to fish, but then you find an area sometimes, Rich, where the fish are plentiful, and then you go back to that area. And you don't always find them in the first spot, do you?
Oh, don't get me started talking on fishing at the end.
That's probably a bad idea.
Get me started at the beginning.
Yeah, well, we would definitely run over and talk about fishing. But it's you're going to have to cast a few times and not catch anything. And then you're going to catch some that maybe you throw back. But you'll find a fishing hole. And once you find one good referral source, you'll get this. It doesn't take to make a busy practice, or even a busy dental sleep practice, it doesn't take hundreds of referral sources, even dozens. 1 or 2 physicians who get this can make a huge difference. They can send you 2 or 3 patients a day if you really get them on board. And so don't give up and persevere, because look, you understand how to do this after this webinar. Don't feel like you've got to wait till tomorrow. We've got all kinds of other education we can help you with, but you all as dentists know as much about apnea. Certainly if you've been to any of our courses or taken any of our other training, you don't feel insecure. You're the dental sleep expert. Our system at DS3 will help you do these steps of dentistry, of dental sleep rather, with less than 45 minutes of time, of the dentist time. And I know, Rich, in my office, it takes less than this. It takes about 30 minutes of my time, and I'm sure it's about the same for you, but we try to set reasonable expectations. This is not something that has to disrupt your daily dental practice. I did dental sleep in my practice along with a busy dental practice. And if you know what you're doing and you know where to plug this in, you can make a lot of money, and you can help your patients in ways you can't even imagine. I mean, if you do 1 device a week, Rich, you're adding almost 6 figures to your income. And if you do, 2 a month, you're still adding a lot. And if you look at that, we're not playing with numbers here. We've got reasonable amounts for the device, a reasonable lab fee, even paying someone else to do your third-party billing. Even if you sign up with a subscription to DS3 for a year, you need to have a plan to do this. And that's what we do. We're answering questions I see coming through here. I want to remind anybody going on a little bit late that if you want to answer any other questions that we're not getting to, or you just want to talk to one of our dental sleep experts, just type in consultation, and we'll contact you. We'll sit down and we'll talk to you about your dental sleep challenges. We have a whole room full of dental sleep experts that's all they do. They spend all their day training dental offices, answering questions, talking about their challenges, and we'll be happy to take some time to talk to you about your challenges and what it is that you want out of dental sleep. And hopefully we can also talk to you about how we can help you with that. But just type in consultation if you want. Also, we mentioned earlier about I know I'm talking quick, Rich, but I want to make sure we got everything through here. The courses, we have several courses still throughout the end of the year, in-person courses. If you just type in course, that'll secure you a $95 discount on any of the courses that we're teaching for the one-day courses. We call them our 4-pillar courses. And Clinical Pearls is coming up in a few weeks, and I think this is the only problem here, Rich, is I looked at some of the PowerPoint I started putting together for this, and this may be part 1 and part 2 before it's over. There's a lot of stuff we have that we can go over here, so I have to figure out what's the most important.
We're going to have to talk about that, and I think you're right. There's too much there, so we may break that up into something that's reasonable, and we hope that you guys can join us for that. Thank you guys for tuning in tonight. Guy, thank you for putting that together. You did a great job as usual.
Well, thank you. I want to mention, if anybody hasn't subscribed to Dental Sleep Insider, we do this every other month. There's fantastic articles, videos about all of the things that can help your dental sleep practice. And you know what? Best of all, it's free. It comes to your inbox. So that's where you sign up for it. And let's see here, Rich, I'll leave this one up. This is what we do. We talk about this 4 pillars: screening, testing, treating, and billing. And people say, well, what is DS3? What is DS3 experience? we help with education, coaching, software, and support. That sounds pretty big, but it is big. We have a team full of a dozen or so team members that just help with each of those aspects. And it starts with our DS3 experience, where we have online modules that are very condensed now to 4 to 6 hours. 4 sessions, 6 to 8 hours, and you can have this up and running in your practice. If that's not enough, we have the ongoing coaching and support, and of course we have the best cloud-based software out there to help you with this. How you get in touch with us, you can just type in consultation into the question box now, or the course, or you can contact us here. And so that being said, Rich, where are we at with the questions? So look at that. We got finished pretty close to on time. Or the questions, let me pull up the questions here, and we'll be happy to stay on with answer any that anybody has that we haven't gotten to. It looks like most of them are checked off here.
No, it looks good. You know, this is, you don't have to reinvent the wheel here. You know,
Right.
we are unbelievably reasonably priced. In fact, that's probably a hang up for some people, that you get as much as you do for as little as you pay. But that guy and I started this just to help dentists do this, and that's what we've been doing for a decade now. So we have been successful at doing this, and now we're trying to get successful at helping other dentists do it. And you don't have to reinvent the wheel. So we hope that you certainly got something out of this. Guy, that was a very good overview of how to do this. So you got to persevere, and you got to learn a few things, and don't go in there blind. Have a plan. You know, how can we help each other help our patients, I think is a very good attitude to have. And I think you'll be quite surprised at how open some of these people are.
We are, and I think if you go back to those 2 slides, you know, you're going to get some rejection, and you're going to persevere. And if you just put those 2 things, just, you know, physicians are good people. They care about their patients. You just have to be confident enough to share with them how you can be involved in that help. I think that's a really good way to look at it. It's, you know, I want to help your patients too. And, you know, if they're on CPAP, and that's great. You know, we're looking for the where we fit in. We're not trying to take things away. We're trying to add help to their patients. And we really are. And I think if you have that attitude, I enjoy meeting with physicians, Rich. I think I wish I had more time in my life to even do it. It's one of the things that I wouldn't say I'm not apprehensive. It's something that if I have a meeting with a physician the next day, I'm actually looking forward to it. It's I learned something. It's nice to talk to other smart and informed people that have similar interest in helping patients. And you should look at it as an exciting opportunity, not as something that should stress you.
Very good. Guy, I think they might stay on for just a couple more minutes, because there's, you know, some people are logging off and trying to get to dinner.
Yeah.
You probably already had dinner, haven't you?
Yeah, but I know you had to stay at your office, and your wife probably had to eat by herself tonight. So if you need to get off,
if you looked at me, you think I could go sometime without eating a meal. But yeah. So I don't know anything else in there, Guy. You see, you know, I think if you know, there's this thing there with physician tells me he already refers to Dr. Smith, you know, something like that. Well, that's okay, you know. How about you or your wife? You know, could I make one for free on, you know, does your wife snore? Oh yeah. Freight train. Well, can I do one for free on her? You know, you got to figure out a way. It's no different than, you know, you're a general dentist and you want the orthodontist to refer to you, or you're an orthodontist and you want all the general dentists to refer to you. It's about relationships. You have to get to know these people. If the guy refers to Dr. Smith and he plays golf with him, you know, twice a week, I'd probably go to somebody else. You know, this is that we're just not going to catch that fish. But there are a lot of fish out there, and, you know, you're going to hit it off with some people and you're not with others. I think most physicians can see through, they can see whether or not you want to help your patients. And if you really want to help your patients and you're willing to work with their insurance and lower their out-of-pocket, and work with them on some of these types of things, then you will really start to win over some of these physicians. And understand that it's a process. It's not just a one-time thing. You can't water that plant once and it grows forever. You got to keep going back, and you got to do that.
And I'd add to that, so I would ask how that relationship's going. So back to the physician who refers to someone else. Okay, great. Well, tell me about that. How are they treating your patients? What do you like about what they do? What do you don't like, if anything? Are they doing everything you can? Do they see most of your patients? Are they dealing with insurance? So if you start talking to them, I'll bet you'll find that there might be some areas that you can improve upon from that relationship. And if you can carry the conversation in that direction, then you can talk to them about, well, you know what, maybe it's insurance they don't deal with. Well, we do deal with insurance, or maybe they don't get the patients back or communicate as well. Well, you can identify those areas and talk to them. Yeah, if it's their best friend, if it's their brother, or best friend growing up or something, yeah, you may. But most of the time, you can find an area that you can improve upon. And again, being confident and not worrying about rejection. And if they don't refer to you the first time, the next time they might. I've had physicians that the door's not really even been cracked open, and then eventually they get it and they become good referral sources. So that's a great question.
Yeah, and there is one there too, Guy, about non-sleep MD. So, I have some of my best referral sources are primary care physicians. I have a couple of rheumatologists that refer me quite a few patients. We call one guy Dr. Itis because every one of his patients has some kind of itis disease, And we always, it's like you said, ding, ding, we ring a bell. Hey, we got another referral from Dr. Itis. And you just got to find people that get it. Most physicians out there are learning more about sleep. It's in more of their journals. They're understanding that if patients don't sleep well, their patients don't do as well.
Yeah.
So even if it's a patient that has fibromyalgia or, rheumatoid arthritis or, something like that. So you got to figure out what it is, where that common ground is. You guys both care about these patients. If people don't sleep well, they don't feel well and they don't do well. So, yes, my biggest referral sources are non-sleep MDs, but it has taken me years to develop that. But you gotta, think back to that story I told Guy about the ENT. He wouldn't sign the letter of medical necessity. Man, I wasn't on the phone with that guy 60 seconds. And now he refers me a patient every week. So that is that perseverance rejection. You gotta stand up and fight for some of this.
Absolutely. Well, I don't see any more coming through. I look forward to our next webinar with the Pearls in a few weeks. In the meantime, if you need anything, just pick up the phone and give us a call, send us an email. I don't think there's any other organization like ours that really exists just to help dentists succeed in dental sleep medicine. There's other ones out there that fill some of the parts of the puzzle, but that's our job, is to put all those pieces together, help dentists succeed, and we enjoy doing it, and we wouldn't enjoy doing it if we didn't get a lot of positive feedback from our members who use our system. So thanks for taking the time, Rich. Thanks for staying over at your office late. Glad we got the microphone thing worked out, and get on home and get you some dinner, and have a good night, everybody. I'm gonna take us sign us off.
Thank you, guys. Thanks again. Stay in touch. Thanks, guys. Bye.